All right, moving on, I would like to introduce our next speaker who's going to talk to us about genetics today. I'd like to welcome Forum Shah, who is a cancer genetic counselor, and she is part of the high-risk cancer genetics program at Perlmutter Cancer Center.
Morning, everybody. So I'm really just going to focus not only on genetics, but the inherited predisposition that's linked to breast cancer specifically, and what happens if a person does not have this inherited predisposition. What does that mean for them? So I thought I'd start by just talking about cancer, and these are the top 10 cancers that we're seeing in the United States right now. And you can see that female breast cancer is the number one cancer up there. We say about 12% of women, and this number does fluctuate based on ethnicity, but we say about 12% of women, or 1 in 8, will develop breast cancer in their lifetime. But the average age of that breast cancer tends to be in the 60s, so we're saying a little bit later on in life. And some of the risk factors that can impact that are our breast history, right? So whether we have abnormalities in our breast, whether we have breasts that are very dense, whether we've had to do biopsies because there have been cysts, all of that is going to impact or sometimes even slightly increase our risk to develop breast cancer. There's also our reproductive factors. So when we start menstruating, when we stop menstruating, our pregnancy history, whether we choose to have children or not, whether we choose to do fertility treatments to help us have children, whether we take birth control or not, and a hormone replacement therapy, breastfeeding, all of those are factors that can actually increase or decrease one's risk to develop breast cancer based on when they occur. And then there's our lifestyle. So just like this great talk we had, having a high BMI can increase our risk to develop cancer. How physically active we are, our smoking and tobacco use, our alcohol use, and our environmental exposures as well. All of that kind of creates this combination of risk that we just get throughout our lifetime. And then really what I'm here to talk to you about are the risks that we have when it comes through our family history and our genetic predisposition. So that's really going to be the focus of my talk today. So we know that majority of the time, 70% of the time, cancer is sporadic, meaning it is just happening by chance. And when we're talking about sporadic cancers, most of these cancers are happening around the average age of diagnosis, in our 60s or 70s later on in life. We know about 15 to 20% of the time, cancer is due to a familial cluster is really what we call it. And what I always say is that's a combination of our lifestyle, the way we lead our life, and somewhat of our genetic information kind of coming in to assist us. So if we have very dense breasts, that's something that's genetically something we inherited. We can't change that, but our lifestyle is something we do control. And then about 5 to 10% of the pie, which is actually a very small percentage, is that hereditary predisposition. That is a genetic mutation or change that has been passed down in the family. It's not a surprise. It's something that's been coming down through the generations, and that is going to impact our risk to develop breast cancer. So what are some of the indications that somebody could fit into this hereditary risk group category? They're listed right here. So having a personal or family history of breast cancer happening at 50 or younger, because remember, average age is 62. So when we're saying 50 and younger, that's significantly younger than that average age. Having a very specific type of breast cancer, triple negative, like Dr. Joseph was talking about, which we are seeing a higher frequency of in African American women, at an age 60 and younger, does put somebody at a more likely risk to have this hereditary predisposition. A woman developing breast cancer more than once in her lifetime, that is a little unusual, and so we always say that that could indicate that there could be this hereditary predisposition. Rare cancers, so male breast cancer is very rare. We say about 1 in 1,000 men will develop breast cancer in their lifetime. So if you're having a family history of male breast cancer, which is very, very rare, we're going to be concerned that there might be hereditary predisposition. Other rare cancers like ovarian and pancreatic cancer, we say less than 2% of the population will develop either of those cancers. So if we're seeing rare cancers in the family, that also will indicate that there might be a hereditary predisposition. And a very aggressive type of prostate cancer can also indicate that. And of course, our ancestry, there are certain populations that we know of that are at a higher risk to carry inherited predispositions opposed to other populations that we know of. So the best way for me as a genetic counselor to gauge whether or not somebody is going to fit into this hereditary risk category is to draw a family tree. And I would not be a genetic counselor if I did not put a family tree up here, right? So this is your family tree, and it's a diagram, and I know it looks a little complicated, so I'm going to walk you through it. But circles are females and squares are males. The arrow is pointing to my patient right there. Below my patient are her children. Next to my patient is her sibling, and in this case, because it's a square, we know she has a brother. Below my patient's brother is her niece. Above my patient are her parents. Next to my patient's mother is my patient's maternal aunt or her mother's sister. And next to my patient's father are her father's siblings or my patient's paternal aunts and uncles. And above my patient's parents are her grandparents. And the reason we draw family trees like this is because we want to see patterns. Patterns are what help us gauge whether or not somebody could have this hereditary predisposition or not. And if you note, there are women in this family that have pink coloring inside their circles, and that is to indicate that these women all have breast cancer. And I'm trying to gauge, okay, if all these women have breast cancer, what is my patient's risk now? Could she have this hereditary predisposition? I am going to get back to this family tree in a bit, but I just wanted to give you a general idea of how we gauge somebody could be at a inherited risk. So when we talk about hereditary predisposition, majority of the time, we are talking about BRCA1 and 2. Most of hereditary breast cancer is linked to genes known as BRCA1 and 2. Now, with more testing and advances, we're saying about 20% of the time other genes are associated with inherited breast cancer, but most of the time it's due to these BRCA1 and 2 genes. And I will be talking about both categories, but I'm going to start with what is the most common. So BRCA1 and 2, they're good genes. There's a misconception that when we do not have the gene, that is what's causing us to be put at a higher risk for cancer. And that's kind of true, but not very accurate. So we all have these genes. Men and women have 2 copies of each gene because we get one from our mother and one from our father. And these genes are responsible for preventing cancer from occurring within our bodies. So in women, BRCA1 and 2 work on our breast and ovarian tissues to make sure cancer does not happen. And in men, they work on the men's breast tissue and prostate tissue to make sure cancers do not occur. So when these genes are functioning and working and doing their job, cancer is actually being prevented. When we talk about inherited predisposition, what we're saying is that these individuals are born with either copy, BRCA1 or 2, not functioning. It is a copy that they inherited, this non-functioning copy, from one of their parents. And this is important to note because I hear this a lot. It doesn't matter if the breast cancer is on your father's side of the family. You can inherit this from either of your parents. So this is risk that you're going to be getting from either your mother or your father. It doesn't matter that it's being passed down from a male generation and therefore you wouldn't be at risk for it. It's just as important. So what are the cancers that are increased when somebody has this change in BRCA1 and 2? And I'm kind of going to go over those numbers with you. And the one thing I want you to keep in mind is that I am quoting the highest numbers that are out there. And these numbers do get adjusted based on a person's age, personal history, and their family history as well. Okay? So these are all the cancers. When somebody has a change in BRCA1 and 2, they have a syndrome known as BRCA-related hereditary breast and ovarian cancer syndrome. Now, this name change is a very recent name change. The syndrome used to be known as hereditary breast and ovarian cancer syndrome. And the reason why we changed the name is because it's misleading. Everybody thinks, oh, it's breast and ovarian cancer. Men don't even need to think about this. Men don't need to concern themselves with this. And that's actually not true because you can see in my diagram that prostate prostate cancer, pancreatic cancer, male breast cancer, and melanoma are all things that are going to be affecting men. And obviously the melanoma and pancreatic cancer can affect the women as well. And so we very recently have changed the name to try and not be as misleading about it. It's a slow change, but we're getting there, and education is one of the biggest ways to get there. So I'll start with what is the highest risk associated with this syndrome, and that is that breast cancer risk. So like I said, we say about 12% of women will develop breast cancer in their lifetime. But when somebody has this syndrome, this inherited predisposition, they have up to an 80% risk to develop a primary breast cancer. Now, if you'll note, it doesn't say 100%. So just because you have this syndrome doesn't mean you're going to develop cancer. It's putting you at a significantly higher risk, but doesn't mean you will get cancer. It's important to note, because I have a lot of men and women come into my office and say, I already have cancer. I don't need to do this testing. I already got the disease. And it's important to note, and you can see this up here, that there is a significantly increased risk for a second primary breast cancer in these women who have this syndrome. So just because you've had breast cancer once, if you have this syndrome, you're at a significantly higher risk to develop a second completely new breast cancer, in addition to all the other cancers like the ovarian and the melanoma and the pancreas as well. So just because a person has cancer doesn't mean that this testing isn't going to have significance for them as well as their family. When somebody gets put into this high-risk category, we do increase their screening. So our breast cancer management, we recommend clinical breast exams are usually done annually. Somebody who has the syndrome, we say every 6 to 12 months. Everybody should be doing annual mammograms, right? But we do start recommending annual breast MRIs as well in these women, and we start them at 25. So mammograms are started from 25 to 30. Once a woman hits 30, we do annual mammograms and breast MRIs. So you can see that we're increasing screening for these women. Some women will choose to remove both their breast, whether they are affected or unaffected. Some women will do it before they get cancer because of their family history or their preference. Other women do it when they've been diagnosed with cancer and they're already considering removing one breast. It's a very personal choice. It is a very discussed choice with physicians, the genetic counselor, plastics, everybody, because it is a big change that a person will be going through. And we do consider chemo prevention as well in these women based on their lifestyle. Sometimes we'll discuss that as well. Ovarian cancer is rare. Like I said, less than 2% of women will ever develop ovarian cancer in their lifetime. But when somebody has this inherited predisposition, you can see with this syndrome specifically that risk for ovarian cancer could be as high as 63%. Now, the difficult thing about ovarian cancer is, unlike breast cancer, where we have great screening tools like a mammogram and an MRI and clinical breast exams, we don't have great screening tools for ovarian cancer. You could consider doing transvaginal ultrasounds, but our ovaries are very, very tiny, and an ultrasound doesn't get up high enough for us to actually be able to clearly see our ovaries to gauge whether there could be cancer or not. There's a blood test we can do to look at our CA-125 levels, but once again, it's not a very accurate blood test at detecting ovarian cancer early on. It's great once a person unfortunately has later stage ovarian cancer for us to confirm that a person has ovarian cancer, but it's not a great screening tool to try and catch this cancer early. So when somebody has such a significantly high risk for ovarian cancer, the recommendation is really to remove the ovaries. And we say that the best time to do this is once somebody is done having children, so it's not like we're putting a rush on that, and close to menopause. So anywhere between 35 to 40. With BRCA2, the risk is even lower, so we say 40 to 45. Those are the ages that we at least start having the discussion with these women. Around 40 is when we start saying maybe it's something you need to start considering doing sooner rather than later. Okay? And then there are these increased risks for other cancers. So prostate cancer, 12% of men get prostate cancer in their lifetime, but it's usually a slow-growing cancer. Most of the time it's untreated. It happens much later on in our life. And you can see that there is that increased risk, and I say it's up to 20%, which doesn't sound high when you compare it to some of the other numbers. But it's important to note that when we're talking about this syndrome, it's not just the fact that men get prostate cancer, it's the fact that they get it in their 40s and they get a very aggressive type of prostate cancer. So if left untreated, it can be fatal. And then there's the slightly increased risk for pancreatic cancer, male breast cancer. Remember, I quoted a 1 in 1,000 chance a man will get breast cancer. So to be quoting a 0.1% versus a 7% chance is a significantly increased risk for these men. And then melanoma, we're thinking there's this association, but we just don't have exact numbers for it. So some of the managements we'll do for these cancers is we'll do a blood screening on men. We'll consider doing digital rectal exams to screen for that prostate cancer. Annual clinical breast exams for men is what we recommend when they have this syndrome. And we started at 35. So it's a fairly young age for a man to start considering doing clinical breast exams when most men aren't even thinking about that. And then that pancreatic cancer and melanoma management is really based on a person's family history. And that's why I say it's really important to ask family members those questions or to share your information so other family members can go and get the appropriate screening that they need to be doing, because our family history will dictate a lot of the times the types of screenings we get, as well as when we start doing those screenings. So there are other genes, right? So BRCA1 and 2 is the most common cause of inherited breast cancer, but it isn't the only cause of inherited breast cancer. And there are other genes, and this diagram's gonna be slightly overwhelming, but we're gonna go through it. These are all the genes we know of that have been linked to breast cancer. And you can see that BRCA1 and 2 is that first one listed here, but then there are at least another 19 genes up there that have been linked to breast cancer. It's much rarer to find a change in some of these genes, but they exist, and each gene has its own risk for breast cancer. And you can see some of these genes have just as high a risk as BRCA1 and 2. But other genes have a significantly lower risk, but it's still increased, and therefore we're going to watch these individuals closely. Each gene, I always say, has its own category of cancers that it prevents. So some of these genes work on our breast and our ovaries. Some of these genes work on our breast and our uterus. Others work on our breast and colon, breast and pancreatic. Each gene has its own story to tell. And keep in mind that our family history is also going to alter how significantly changes in these genes are going to impact our management. Management when it comes to breast cancer prevention, depending on the gene and depending on our family history, most of these women will be getting annual mammograms and annual breast MRIs. But whether we consider offering them bilateral mastectomies or removing one's breast is really going to depend on the gene that they come back positive for, as well as their family history. Now, nobody here is going to say absolutely not, you cannot remove your breast, right? We're not here to make your decisions for you, but we are here to educate you about whether or not that seems like something that's going to really truly be a preventive measure or something that we would consider to be not necessary. Okay. If somebody has done testing over 5 years ago, my advice is always to return for an updated risk assessment for many reasons. One, you probably didn't do testing for all 20 of these genes, right? So you can come back in and do testing for the rest of these genes. Two, your family history is always changing and altering. And as your family history changes and alters, your risk is changing. As you're getting older and as our lifestyles are changing, that is also going to impact our risk to develop breast cancer. So it's really important that you come back in for updated information, or at least call your genetic counselor if you have one every 3 to 5 years and check in with them and say, is there anything more I should be worried about? Or hey, here's a change in my family history you didn't know about. Is this going to change anything when it comes to my risk assessment? Okay. So because this is a presentation for minority women, I thought I'd talk a little bit about their access to genetic testing. And a lot of this came from publications. I don't have all the information, but this is what the publications were able to give me. And what we found is that when compared to non-Hispanic white women, African American women were 16 times less likely to be offered genetic testing. And Hispanic women were 2 times less likely to be offered the option of genetic testing. And that in itself is a big discrepancy, right? Why is it that women of color are being less likely offered this genetic testing? Is it a presumption on the physician's part? Is it partly due to the patient? The article I talked about kind of lists some of these reasons, and I'll go over them with you, but it's a big discrepancy right here. Even when it came to the actual genetic testing, 47% or about 50% of white women underwent BRCA genetic testing compared to about 26% of African American women. So white women are 2 times as more likely to even do the genetic testing when compared to women of color. And some of the reasons that these articles listed had to do with the patients reporting. So they were saying patients were reporting incomplete family histories. Patients didn't know. So they're coming in with one breast cancer. They themselves have breast cancer, but they don't know about their family history, and therefore doctors or physicians or providers didn't think to refer them to a genetic counselor or think to offer them genetic testing because they didn't realize it. The one bias to that is that women of color, like African American women, are more likely diagnosed with triple negative breast cancer. And even if they know nothing about their family history, that is an automatic ticket to genetic counseling. So it's a little bit iffy as to why that's not happening. There was this distrust of genetic testing and this fear of discrimination, right? So women of color were more fearful that if they're going to have this genetic testing, then maybe they're going to be discriminated against. They're barely getting coverage for all of these services as is, and all of a sudden they're going to do this testing that may tell them that they're at a higher risk for cancer, and there was just this fear that went with it. Just as a sidebar, we do have a law in place, and it is known as GINA, that protects women against men and women, or all individuals, against discrimination. Health insurance and employers, and what I always say to patients is, I don't know how your employers would find out this information, but if they did, cannot discriminate against you based on that. So your health insurance coverage cannot go up, or they cannot drop you from coverage. Employers cannot make any hiring, firing, or promotion decisions based on your genetic test results alone, okay? The law doesn't protect against life insurance coverage and long-term care. So anytime I have a patient come in to see me, that is information I give them ahead of time. Just because a patient comes in to speak to a genetic counselor doesn't necessarily mean they will be doing this genetic testing. It really just means they're coming to speak to somebody and get information about this testing. And so that is a piece that we can use and providers can use in kind of eliminating that fear of discrimination that women may be feeling. And then the third reason is there was worry over the cost of testing, right? And so genetic testing is very expensive. The first time we tried to sequence the human genome, it was millions of dollars, right? But now we can do it for about $700. And you can see that huge change that has occurred. So to give you a better idea of cancer genetic testing, when I first got into this field about 5 years ago, and I had to tell a patient, unfortunately, your insurance isn't going to cover it, you would have to pay for this test, it would cost a patient $4,400 to do this genetic testing. And it was very difficult as a provider to say something like that to a patient. Nowadays, if a patient is choosing to pay for this testing out of pocket, not through their insurance, the test can be anywhere between $150 to $250. It's still a significantly increased amount to many people, and I completely understand that, but you can see that we've now gone from $4,500 to between $100 to $200, and you can just see that change because of the advances in our technology. The other advance is when people would come in to see me, I would tell them it's going to take 3 to 4 months to get their genetic test results back. And now I can say it takes between 2 to 3 weeks to get those genetic test results back, which is great because a lot of women are waiting on these results to kind of help them decide what type of treatment they may want to pursue, including surgeries. Okay, and so that worry over cost of testing has gone down significantly. Additionally, the laboratories we work with, I'm very picky about the laboratories I work with. I demand the best for my patients. And so the laboratories we work with have financial hardship programs in place so that patients who cannot afford this testing are able to do this testing for free because they meet their hardship criteria. So back to this family tree. I told you I'd come back to it. So there's my patient. She's 40 years old. She doesn't have any cancer, but she's worried she's going to get cancer because her mother had breast cancer in her 60s. Her mother's sister, so her aunt, had breast cancer in the 50s, which is a little bit younger than that average age we'd expect. And more importantly, her mother's mother had breast cancer at 49, which is significantly younger than that average age that we expect somebody to have breast cancer. There are 3 women in this family with breast cancer, and you could say, based on this family tree, that all the women in this family have been diagnosed with breast cancer. So this patient is rightfully concerned that she might be put at a higher risk for cancer. So she came in, we did the genetic testing. We always prefer to do genetic testing on somebody who has the cancer, who has the very young cancers in the family. In this situation, we can't. Unfortunately, all the women are deceased. And so we do go ahead and test the patient in this instance. We just give the patient a caveat, which is that sometimes we may not get all the answers. And in this case, that's what ended up happening. The patient tested negative. She didn't have an inherited predisposition to cancer. So I couldn't answer this question of why are all the women in my family developing breast cancer at such young ages? And at that point, given the number of women in this family with breast cancer, I'm not going to say that this person's breast cancer family history is sporadic, meaning it's random. It's obviously not random. There's obviously something going on in this family. And that's where that familial category comes into place. That category that there is the significant history of cancer in the family. Something is causing it. There must be some genetic risk that's coming through, but it must not just be genetic risk. It must be a combination of many things. And what do we do in an instance like this, right? So a lot of people think, I just want this testing. I want to test negative. I never have to worry about cancer again because I've tested negative. I don't have to think about it again. And unfortunately, that's not the case, right? Testing negative for an inherited predisposition doesn't mean that the family history automatically disappears. Our family history will always be our family history. And so what I did for this individual is we have risk models. We have models, and these are several, that we use to help a woman gauge what is her risk going to be to develop breast cancer now that she has tested negative. What is this risk going to be? These risk models, this is an example of one. You can see it takes a lot of things into consideration. It takes the woman's personal history into consideration. If she's had a child, when she started menstruating, her breast history, if she's had abnormalities in her breast or not, her height, her weight, whether she's menstruating right now or not, whether she's taken hormone replacement therapy. And then importantly, her family history is on there as well. You can indicate who's had cancer in the family and if anybody has done genetic testing. And based on that, these risk models are able to give us a general idea of what is this woman's risk to develop breast cancer when compared to the general population. So in my patient's case, this is the output that the model gave me. And what it told me is that her lifetime risk to develop breast cancer was about 27%. So that's 2 times the general population risk. That it's twice the 12% risk, right? And when somebody fits into such a high risk to develop breast cancer, and keep in mind that this risk wasn't just based on her family history, it was also based on her personal risk factors, right? So we, of course, do general population screening. The self-breast exams, clinical breast exams every 6 to 12 months, and the annual mammograms. But in her instance, I'm going to be adding in annual breast MRIs as well. Okay, so you don't have to have an inherited predisposition to get increased screening. And I think that's important to note and remember because a lot of women think, I just want this testing so I can get extra screening, but you don't always have to do this testing. Your family history itself may indicate that you need extra screening anyways. Okay. So in summary, hereditary predisposition is really a small piece of it, right? It's if you really look at it, it's only 5 to 10% of the pie. But our family history is going to more significantly be impacting our risk than anything else. If you can test negative and still be considered at a high risk for cancer. You have to always be your advocate. So if you've had genetic testing, it's going to be up to you to check in with your providers every couple of years to make sure that you have the most up-to-date testing, and not just with genetic testing, pretty much with everything, right? It's going to be up to you. Unfortunately, we as providers cannot contact all of our patients constantly to make sure that they're doing the most comprehensive updates. It's going to be up to us to go and advocate for ourselves. And make sure to clarify your family family history, make sure to share that information with your family as well. It's important for you, nieces, nephews, children, cousins. Even cousins are going to be impacted by this risk. And so it's important that not only do you gauge your family history, but you share your personal information with them as well. I'm not saying you have to give them all the medical history, but kind of just give them a chance to be preventive like we would all want to be. Thank you.